Hello, I'm Dr. Jha, Director of Renal Skin Health Clinic. Today I have opportunity to meet Mr. Menon, who happens to be a consultant general surgeon as well as bariatric surgeon at University Hospitals of Coventry, which is also known as Walsgrave Hospital. And today we'll talk about obesity surgery. So Mr. Menon, tell me a little bit about obesity surgery. The clients want to know what are things available and so on.
Thank you, Dr. Jha. Thank you for inviting me and asking a question. To put it very simply, there are 3 operations available for patients seeking bariatric surgery: the gastric band, the sleeve gastrectomy, and the gastric bypass. Gastric band, I could call it the simplest of the 3 options, because it is a reversible procedure. The band is inserted by keyhole technique, laparoscopic surgery. Patients need to stay in hospital possibly overnight. In the rare cases, we even do them as day cases.
Sure.
It is suitable for patients with a body mass index of more than 40 or body mass index of more than 35 with treatable comorbidity like type 2 diabetes and hypertension. The patients need to work with the band and with the surgeon and with the dietitians, because theoretically you could always cheat a band. You could still have 3 or 4 Mars bars in a blender and drink. I'm not saying for once that a patient seeking attention would do that, but people need to be aware that it is possible to cheat a band. It is there is no science involved. It's a purely restrictive operation. It restricts the amount of food that one eats. The band is placed around the top part of the stomach. So instead of having the big stomach, as we all have, available to take in 3 or 4 course meal, instead of that you have a small golf ball sized pouch on north of the band, so that you eat a small amount, we feel full, it sends signals to the brain saying you're full, you've got to stop, and then you stop, and then after a while the food or fluid goes through the middle portion of the band into the rest of the stomach and goes through the normal route that food takes now.
Sure.
And then when you feel hungry again, you eat a small portion. So once you're used to small portions, your intake would be much less than what you're used to otherwise. So by pure restriction, one loses weight. The beauty of the band is that the weight loss is gradual. So people would say, oh, you're looking fitter, you're looking healthy, have you lost some weight, you're looking really nice, instead of, oh, what's happened to you, you've lost weight, you're looking sullen, you're looking tired. So that doesn't happen. It's a measured gradual weight loss. And if you look at patients who work well with the band, over a period of 9 to 12 months, you could lose about 60-65% of your excess body weight.
Oh, that's excellent.
That's excellent. And that you don't need to lose that much. You lose 2 stone, 3 stone, and the sense of physical and mental well-being is huge. You're a changed person.
Yeah.
So that's the benefit. There are, as with any operation, there are complications.
So the risk of diabetes or risk for blood pressure or cardiac problems or arthritis, all those things can be minimized.
It can be. I'm not saying all the comorbidities will disappear, but they will certainly improve, and there's a good chance of resolution of several of these. And you got to work, and when I stress that again, you got to work very closely with the band, yourself, and with the surgeon and the dietitian. That's key. You asked about some complications. There's no surgical operation that has got any complications or side effects. As with any operation, there is a small risk of the general anesthetic, but we minimize that with anesthetic assessment and risk factor control. Small risk of bleeding and infection, as with any form of surgery. The band sits around the top part of the stomach, and we put some stitches to prevent the band slipping north or south. That is called band migration, and we prevent that by using the stitches at the time. We do not fill the band too early, because if you fill the band too early, it can damage the lining of the stomach. And the band, instead of sitting outside the stomach, could eat through the wall of the stomach and come to lie inside. That's called a band erosion. So these are the common complications, and hopefully I have explained how we try to avoid or minimize it.
Sure.
And the chance of successful keyhole surgery is 95%.
That's very good.
So that's in summary about a band. The band goes from the top part of the stomach. There's a plastic tubing which comes to a little port or a little reservoir which comes on the left side of the tummy underneath on top of the muscle, underneath the skin, which you can feel but not see. And that's where the radiologist would put needles and put fluid in so that the band can be filled, inflated or deflated. And that's how it works.
Yeah,
The band.
sure. And these surgeries, are they available through NHS?
They are available through NHS, exactly the same criteria we discussed before. The NHS follows the NICE guidance, which is what all practitioners in the UK would follow. But the threshold for different PCTs as they exist today is much higher for quite the right reasons, because they've got a finite pot of money and they've got to ration it towards all services, emergency surgery, elective surgery and bariatric surgery. So there is a good group of patients who get it through the NHS, because you've got to wait, got to be assessed by the surgeons, the physicians, the dietitians and all the medical obesity team. You should have shown a commitment towards a weight loss program and fitted the threshold which the respective PCTs have set. So there would be a group of patients, a big group of patients, who are eligible as per the NICE guidance, but do not fulfill the criteria for the respective primary care trust.
Sure.
And that's where providers like yourself have got a huge role to play in pointing these patients in the right direction.
Absolutely. Yes, fantastic. And as you said, that is either a day case procedure?
I think most patients have it with overnight stay.
Overnight
because
stay.
you need to.
So even if the client is coming from, say, Leicester or Manchester,
we have
no problem.
no
we can
problem.
accommodate.
We have patients who have come in from Northern Ireland, had a band, stayed in overnight in hospital, and overnight in one of the the hotels near the airport, and flown back the following day.
One day.
Yeah.
And how often do you see them?
The follow-up is very standard. After any gastric band procedure, I see them 2 weeks following surgery. In fact, this morning I saw 2 patients I put bands in a couple of weeks ago.
Sure.
The dietitian sees them at week 4.
And they can see the dietitian locally, can't they?
Oh, locally. Oh, yeah. And once the immediate post-operative phase is over, a surgical follow-up is not absolutely necessary. You can be followed up by the dietitian or by the radiologist to have the band fill and the band x-ray. But the dietitian is absolutely crucial, and I want to stress that again. The success of the band depends on how well you work with them and how competent and reassuring the dietitian is.
So what is the life of these bands?
The bands are theoretically lifelong.
Right.
Since 1993, in the last sort of 18-19 years, there must have been at least 500,000 bands put in worldwide. But only less than 10% have ever had to come out. That is because of any complication, as we discussed before, a band erosion or a band migration. Even if a patient has achieved the desired weight loss, we don't need to remove the band. In fact, removal of a healthy band could cause more problems. But you could deflate the band, empty it, and that could...
And how do you deflate it?
Just taking the fluid off the port, which you can easily feel on the abdominal wall.
Right.
You need to put in a needle and empty the band.
So on the surface of the skin there is no...
No, on the surface of the skin there is a scar from where the port went in.
Right.
These patients have a fairly thick segment of fat between the abdominal wall muscle and the skin. So we create a good pocket which sits on the muscle of the tummy wall and fix the port there, so you can feel it but not see it.
That's very important.
That's the reason why I always put the ports there. Some surgeons quite rightly put the ports just underneath the breastbone. It's easier to access it, to inflate and deflate. But once patients lose weight and they become more self-conscious and they want to go to it's there, you can see it. So I always do it on the left side.
Excellent. Well, thank you very much.
Thank you.
Thank you.